The following video has been developed by Cancer Care Ontario for the GI Endoscopy Data Submission Portal. Dr. Jill Tinmouth, a gastroenterologist and the Provincial Scientific Lead for the Colon Cancer Check Program, will be walking you through the definitions of key data elements and their significance for submission.
Welcome to Cancer Care Ontario's Data Submission Portal, often referred to as the DSP. This portal is used to submit colonoscopy data within the GI endoscopy program. In this video, we will be going over the GI endoscopy DSP data elements. We will be providing more detail on how each data element is reported and its importance. The information collected through the DSP will improve the quality of patient care and increase reporting accountability and transparency. First, standardizing data submission will provide less complexity around data reporting, since the DSP is a tool commonly used for other Cancer Care Ontario programs and currently supports more than 500 users. Improved data quality will result from the DSP's ability to validate data as well as the enhanced minimum data set. The DSP will also enhance access to reporting, as all hospitals in the province will have access to reports. Furthermore, it will support methodologic enhancements for the indicators and measures used in these reports. From a performance management perspective, the new platform will support all three programs: Colon Cancer Check, Quality-Based Procedures, and the Quality Management Partnership, which are intended to increase the quality of colonoscopy procedures in the province. The GI endoscopy DSP data inform the Screening Activity Report, also known as the SAR. The SAR provides primary care physicians with a tool to improve their cancer screening rates and follow-up rates after abnormal FOBT. Lastly, it enables physician-linked correspondence, as screen-eligible patients will receive recall and reminder letters as appropriate. In this table, we have shown the 30 GI endoscopy DSP data elements along with a completion requirement for each. Only those data elements that are clinical or are more complex are highlighted, and these elements will be discussed in further detail during this video. The first data element we will be discussing is the date of receipt of referral. For outpatients, this is the date the colonoscopy referral was received by the hospital or the endoscopist, whichever date is earliest. However, for inpatients, the date of admission into hospital should be used as the date of referral. The original referral date should be entered for colonoscopies that did not take place when originally booked and were subsequently rescheduled by the facility. In cases where there is no referral date available, please enter 0. Typically, 0 should only be entered if a patient is being recalled, either for colonoscopy as a part of an ongoing cycle of screening or surveillance, or for a repeat colonoscopy due to poor bowel preparation or incomplete polyp excision. The date of receipt of referral is very important, as this data element will be used to calculate wait times. Patient self-delay indicates that the colonoscopy appointment was deferred by the patient after the initial booking or referral. Patient self-delay reflects patient-related reasons that led to a delay in performing the colonoscopy. These reasons include, but are not limited to, the patient chooses to defer, the patient is traveling, inability to contact or reach the patient medical status is changed. The patient self-delayed data element will be used as an exclusion criterion in wait time calculations. Cecal intubation is the complete insertion of the colonoscope such that the end of the scope touches the cecal pole and the cecum is completely visualized, including behind the ileocecal valve. In patients who have had a cecal resection, completion is defined as reaching the ileocolonic anastomosis. In this video, we start with a view of the ileocecal valve and the cecum beyond it. In order to meet the definition of intubating the cecum, the colonoscope must be inserted beyond the ileocecal valve as illustrated here. Here, the endoscopist enters the terminal ileum briefly. Although often a part of the exam, this maneuver is not necessary to meet the requirement of cecal intubation. Once in the cecum, careful inspection must be undertaken and the key landmarks, such as the appendiceal orifice, noted. If the colonoscopy was complete, including cases where there has been a prior cecal resection, then enter yes. enter no if the colonoscopy was incomplete for any reason, which may include the diagnosis or discovery of a mass or obstructing lesion during the procedure. If it was planned a priori that the colonoscopy not be complete, that is, if it was being done to tattoo a previously seen cancer, this data element should be entered as not applicable. It is important to note that hospitals that submitted data through the CERT were previously instructed to select not applicable when a patient did not have a cecum. In the GI endoscopy DSP, not applicable should only be used if the intention of the procedure was not to perform a complete colonoscopy. Cecal intubation is a key quality metric. Incomplete colonoscopies are associated with poor outcomes and will be monitored. If not applicable was entered for cecal intubation, a reason must be provided. Examples where not applicable might apply include tattooing a known lesion or resecting a known polyp in the distal colon. This data element will be factored into calculations of the cecal intubation rate, where procedures graded as not applicable for this indicator will be excluded from the cecal intubation calculation. The adequacy of bowel preparation data element is meant to determine how well the bowel was cleaned prior to the colonoscopy. There are three options to assess the adequacy of bowel preparation. The first category we will discuss is very good, which is represented by a V. In this short clip, you will see an example of very good bowel preparation. The bowel preparation is considered very good to excellent when it is good enough to detect lesions of importance. In this short clip, you will see an example of a fair bowel preparation. The bowel preparation is considered fair when irrigation and cleaning are required to remove liquid or semi-solid stool. Typically, additional endoscopy time is needed to improve visualization of the mucosa when the bowel preparation is fair. Poor bowel preparation occurs when there is inadequate visualization of the mucosa resulting from the presence of semi-solid or solid stool that cannot be adequately suctioned or washed. A repeat procedure is required. It is important to grade the bowel preparation for every colonoscopy. Adequate visualization of the colonic mucosa is a critical quality indicator for colonoscopy. Poor bowel preparation is associated with lower adenoma detection rates. ASA grade describes the general physical status of the patient prior to receiving the colonoscopy. ASA grade can be measured by any provider and does not require an anesthesiologist consultation or involvement. The endoscopist or his or her delegate can assess ASA grade. Please note that although the ASA grading system goes from 1 to 6, ASA grade 6 is excluded from the valid value options in the GI endoscopy DSP. Patients should be scored from 1 to 5 based on the following definitions and examples. A score of 1 indicates a healthy patient. For example, a non-smoking patient with no or minimal alcohol use. A score of 2 is for individuals with mild disease without functional limitations, such as those who are current smokers, social alcohol drinkers, obese, or pregnant. To be scored a 3, the patient should have substantive functional limitations, such as active hepatitis, alcohol dependence, an implanted pacemaker, be on dialysis, or have poorly controlled hypertension. To score a 4, the patient should have severe systemic life-threatening disease, such as ongoing cardiac ischemia, severe valvular dysfunction, or sepsis. A score of 5 should rarely be used as it is reserved for moribund patients, including those with ruptured abdominal aortic aneurysms and those who have sustained massive trauma, an intracranial bleed, or multiple organ dysfunction. ASA grade measures patient comorbidity and is a predictor of perioperative morbidity and mortality. Patients with greater comorbidity are at greater risk of complications from colonoscopy. Inclusion of the ASA grade as a DSP data element permits the uniform collection of patient comorbidity data across institutions in Ontario. The abnormal findings present data element reports the gross findings at colonoscopy and has two valid values. The value no indicates that the colonoscopy is normal, that is, a negative colonoscopy, or that it is not possible to determine whether findings were normal or abnormal, for example, because the procedure was incomplete or the bowel preparation was inadequate. Findings of only diverticula or hemorrhoids should be categorized as no abnormal findings present. The value yes indicates that abnormal findings were found. If the abnormal finding data element is reported as yes, then the type of abnormal finding should be selected. There are three options. One or more polyps found. This data element reports that a polyp was seen and/or removed during colonoscopy before confirmation via pathology. Mass or suspected cancer found. If a highly suspicious mass is identified, it should be reported as a mass or suspected cancer. For example, findings reported as likely cancer, probably cancer, or suspicious for cancer should be entered as a mass or suspected cancer in the GI endoscopy DSP. Other abnormal findings. This data element should be reported if something other than a polyp, mass, or suspected cancer was found. For example, findings consistent with colitis, inflammation, lipoma, nodular mucosa, scar, stricture, ulceration, and vascular changes. Diverticula and hemorrhoids are not considered abnormal findings. The importance of collecting this data element is to allow categorization of abnormal findings into those that are precancerous or cancerous and those that are not. The diagnostic or therapeutic procedures performed data element describes additional procedures that were performed at the same time as the colonoscopy. If additional procedures were performed at the time of the colonoscopy, then yes should be entered. Alternatively, if only the colonoscopy was performed, then enter no. If there were any diagnostic or therapeutic procedures performed, then at least one or more of the following data elements must be also entered as yes. Biopsy, non-polypoid tissue. This data element is defined as the removal of non-polypoid colorectal tissue using either hot or cold biopsy forceps. Biopsy polypoid tissue, defined as the removal of polypoid colorectal tissue using either hot or cold biopsy forceps. Snare polypectomy, defined as the removal of a colorectal polyp using either a hot or a cold snare. Other procedures. This data element is defined as any other procedures performed during the colonoscopy, including injection, clipping, or stent placement. If a colorectal cancer is identified and biopsied, indicate yes for biopsy polypoid tissue. This data element provides information on the type of diagnostic or therapeutic procedure performed. In particular, it will provide important information about the management of polyps. If you would like more information on any of the data elements in this video, please refer to the following resources, which are described in the blue boxes. GI Endoscopy DSP Data Dictionary, GI Endoscopy DSP Decision Tree, GI Endoscopy DSP Data Collection Form, ASA Grade Guide, and GI Endoscopy DSP FAQs. Please reach out to your regional cancer program to obtain any of these resources. Thank you for watching this video. We hope you have found it helpful.